Now we come to mood disorder, about which there are two major facts you need to remember. Namely, that it involves an abnormal range of very intense emotions and that patients lack significant control over these emotions, like ha ha ha, hee, ha ha ha, hoo. And as you can imagine, that would cause a lot of distress and anxiety. Now, there are different types of mood disorders, and these include major depressive disorder, bipolar disorder, dysthymic disorder, which is a chronic feeling of depressed mood, cyclothymic disorder, which is an alternating state of hypomania and moderate depression, and that cyclo gives you the clue that it's cycling between hypomania and moderate depression. It's also important to realize that psychotic features like hallucinations and delusions may also be present. And in the setting of a clinical vignette on your exam, for example, focus on looking for clues that suggest the patient's emotions are at the core of their daily life disturbances, as opposed to psychosis, where there would be psychotic features at the core of a person's life disturbances. Now, two very common mood disorders you'll see on the boards are bipolar disorder and major depression. But before we can understand bipolar disorder, we have to define what a manic episode is, because that is what you see in bipolar disorder. So a manic episode is a period of abnormally and persistently elevated mood and activity for at least 1 week. So that is the time period required for the diagnosis. And the patient, in order to be diagnosed, has to have at least 3 of the following criteria. And the way I remember these criteria is with the mnemonic Manic's Dig Fast. And those stand for distractibility, irresponsibility, grandiosity, flight of ideas, which refers to racing thoughts, psychomotor agitation, and increased goal-directed activity. That's to say that they have an obsession with accomplishing some task, decreased need for sleep, and talkativeness or pressured speech. A distinguishing characteristic of a manic episode is that they often are disturbing to the patient and lead to impairment in social and occupational functioning. A hypomanic episode is basically just a milder form of a manic episode where an individual experiences similar symptoms, but they're not as severe and they don't cause as much impairment in functioning related to social and occupational functioning. The symptoms of a hypomanic episode must last for at least 4 consecutive days in order to qualify as a hypomanic episode. Now, be on the lookout for an individual that experiences some of the same 7 criteria we just mentioned for a manic episode, but otherwise has a normal life. And also be on the lookout for the time span. If it's 1 week, you're going to go with what? Manic episode. If it's 4 consecutive days, hypomanic episode. And a lot of med students probably experience a couple of these symptoms for a few days around exam time. So don't go and diagnose yourself with hypomanic episode. So we talked about hypomanic and manic episode, but technically they're not illnesses in and of themselves. They're part of an illness known as bipolar disorder. Now, any individual who has had a single manic or a single hypomanic episode is defined as having bipolar disorder. And this is often difficult for people to understand because the term bipolar or 2 poles suggests that there should be some depressive symptoms along with manic symptoms. And while this is generally true, patients are given the diagnosis of bipolar disorder following a single manic or single hypomanic episode, because these patients will invariably develop depressive symptoms at some point. There are two subcategories of bipolar disorder. In bipolar 1, the patients must have at least one manic episode with or without a hypomanic or depressive episode. In bipolar 2, the patient must have a hypomanic episode and a depressive episode. Between these episodes, patients often stabilize their mood naturally, but sometimes patients are treated with mood stabilizers, and those classically involve lithium, valproic acid, carbamazepine, and atypical antipsychotics. Now, do you think it would be wise to treat these types of patients with antidepressants? No, you should not treat these patients with antidepressants. This is because antidepressants can increase the severity and frequency of manic episodes. Now, a milder form of bipolar disorder is cyclothymic disorder, where patients alternate between hypomanic symptoms and mildly depressed symptoms over a period of at least 2 years. And again, note the time span criteria that you have to have at least 2 years of this alternating between hypomanic and mildly depressed to be diagnosed with cyclothymia. Okay, flash quiz. Name the 7 diagnostic criteria for a manic episode. Remember the mnemonic Manics dig fast, which stands for distractibility, irresponsibility, grandiosity, flight of ideas, psychomotor agitation and increased goal-directed activity, decreased need for sleep, and talkativeness or pressured speech. Now let's look at major depressive disorder, which has 9 clinical criteria that help make the diagnosis of MDD, major depressive disorder. But you need at least 5 out of the 9 for a period of 2 weeks in order to make the diagnosis. Now, the minimum is 2 weeks, but on average, patients with MDD have symptoms for 6 to 12 months. Now, the criteria for diagnosis can be remembered with the mnemonic SIGICAPS, which stands for sleep disturbance, loss of interest, also known as anhedonia, guilt or feelings of worthlessness, loss of energy, loss of concentration, appetite and weight changes, psychomotor retardation or agitation, and by retardation here we mean slowing down, suicidal ideations, and while it's not included in the mnemonic, a depressed mood. This last one is actually the only one of the 9 that the patient must have. You have to have the depressed mood, otherwise it doesn't count as major depressive disorder. So you'll hear this acronym thrown around in the hospital as well, so it's worth committing to memory for more than just test purposes. In terms of epidemiology, the lifetime prevalence is 5 to 12% for males. And would you think it's higher or lower for females? Higher for females, actually, 10 to 25% lifetime prevalence. Patients with major depressive disorder also have changes in their stages of sleep. They have decreased slow wave sleep, decreased REM latency, which is the time period between when you go to sleep and when you go into REM. So that time period decreases, so they're getting to REM faster, and increased total REM sleep. They also experience repeated nighttime awakenings and early morning awakenings. A related disorder, which is referred to as dysthymia, which is also known as persistent depressive disorder, is where patients suffer from a mild form of depression in which symptoms do not meet the criteria of major depression but last for at least 2 years. You may also encounter questions about seasonal affective disorder, which is a form of depression linked to decreased sun exposure during the winter months. And the key to identifying this disease is the resolution of depressive symptoms with increased full spectrum light exposure. Another subtype of major depressive disorder, and also the most common subtype, is atypical depression. And the reason it's atypical is because it's characterized by mood reactivity, which is being able to experience an improved mood to positive events. So positive events lead to an improved mood. These patients also have hypersomnia, they sleep a lot, weight gain due to overeating, and oftentimes these patients will be very sensitive to rejection. Atypical depression is common in younger patients, such as teenagers, and is usually treated with MAO inhibitors or SSRIs. Postpartum patients are subject to many possible mood disturbances, most of which are benign, but some of them are not, and they'll require intervention. Look for the onset of these disturbances within 4 weeks of delivery. Now, the first one is called postpartum blues, and it occurs in 50 to 85% of women. It often manifests with depressed affect and fatigue, but will resolve often within 10 days without any intervention. It's important to follow these women for the development of postpartum depression. So, postpartum depression, or PPD, occurs in 10 to 15% of women, which is also characterized by depressed affect. So PPD also has depressed affect, and this one can actually last from 2 weeks to over a year. And these will more often necessitate treatment, which includes psychotherapy and antidepressants. Again, the key here is to commit to memory the difference in time scale. I really like the alphabetical mnemonics, so I remember that blues come before depression. B for blues, D for depression, so B before D. Just like B becomes before D, therefore postpartum blues is 10 days shorter, and postpartum depression is 2 weeks to over a year. It's longer. Postpartum psychosis is a much more serious clinical entity, though it's uncommon, and it's only seen in 0.1 to 0.2% of women. And it's characterized by sometimes homicidal or suicidal ideations or attempts, and the patients also have delusions. It can occur for up to 4 to 6 weeks. So patients with postpartum psychosis can have these symptoms for up to 4 to 6 weeks. And often it's going to require pharmacological intervention and, if necessary, inpatient hospitalization. The pharmacological intervention involves antipsychotics and antidepressants. Flash quiz. A patient presents with depressed mood, anhedonia, feelings of guilt, loss of concentration, increased appetite, loss of energy, and suicidal ideation. What additional information needs to be obtained to make the diagnosis of major depressive disorder? The time course, of course. Get it? So the symptoms, remember, in MDD have to be present for at least 2 weeks. So you want to ask the patient, have these symptoms been present for most days during the past 2 weeks? Remember, in psychiatry, we have to know the time course of symptoms in order to make diagnoses.